Kimmy, and this is my teaching assignment for acute pancreatitis. First, I'll be going through more of the patient information, some background, and then my nursing diagnosis, followed by my teaching strategies, and I'll go through those specifically, zooming up and explaining each one in detail. So we start off with our SBAR format. We have our situation. There's a 44-year-old male presented to the emergency room. He was displaying severe right lower quadrant abdominal pain, and he had been experiencing this for the past 3 to 4 days. He was unable to keep any fluids down, any food down, frequent episodes of nausea and vomiting, really wasn't doing very well. He denied drinking alcohol prior to this visit, and he reports making unhealthy nutritional choices. Going to our background, he had a previous admission for alcohol-induced pancreatitis 2 months prior to this date. He has a history of alcohol abuse in the past, and he works long days on the road trucking with his brother. Assessment. So he presented to the emergency room with, again, that stabbing and aching pain in his right lower quadrant. He rated that as a 10. Again, that tenderness upon palpation. And then his labs were drawn. He had an elevated lipase, elevated blood alcohol level, decreased red blood cell, and a decreased sodium level. A CT scan was performed that showed free fluid in the pancreas. So the recommendation by the physician was to be admitted to the med-surg unit for acute pancreatitis. The plan of care was that he would be placed on an NPO diet or nothing by mouth so that we could give his stomach a rest. A normal saline infusion at 75 milliliters per hour. Labs to be drawn the next day to reevaluate the situation, see how the medications are going in the plan of care. And then his medications that were ordered were IV Dilaudid as needed for pain every 4 hours, some Colace for constipation. That Dilaudid can really slow down your GI tract, so we want to have that constipation medication in there. IV Protonics for GERD, stopping the acid reflux from occurring. Lovenox for venous thromboembolism prophylaxis, stopping those DVTs. The outcome and timeline, so this is my clinical day when I met my patient. So he had some labs drawn that morning. It did show a decrease in his lipase level. However, it still wasn't within normal limits. It was still elevated outside of normal. At 5:30, he was having some pain, rated on an 8 out of 10. We gave him some IV Dilaudid medication. And at 6 o'clock, I did a pain reassessment where he rated his pain at a 3 out of 10, which was functional for him. At 8:30, we administered some medications. He accepted the Colace and the Protonics, again, for the constipation and the acid reflux. But despite patient education, he refused the Lovenox. He really wasn't very apt to having it. At 8:45, the doctor came in to assess the patient. The doctor ordered to infuse running normal saline as a bolus to keep the patient hydrated. He ordered an advanced diet to general, and then he was planning to discharge the patient if his pain was under control and if he tolerated that diet well. At 10 o'clock, the patient did end up tolerating a piece of toast and a cup of hot chocolate. And then around 11 o'clock, the patient grew a little bit antsy and decided he wanted to go. So we contacted the physician, and he left with his girlfriend after receiving discharge instructions. So some takeaways that we have. The patient, again with his Lovenox, because this is a teaching assessment, I want to highlight how receptive he was to his education. He was rather passive to receiving his Lovenox. He kind of would give me like the shrugs on the shoulders, not really much eye contact there. So really that education does need to be reinforced. Again, coming to my teaching strategies that I'll talk about in a little bit. He did meet with a dietitian though, and the dietitian had a pre-planned, basically a meal plan for him. And he was more receptive to that. He was very interested in looking at it, reading through, probably because he's a trucker on the road. He likes those pre-planned meals, and it just makes his life a lot easier. He can say, this is what I want. So that kind of comes into play with my teaching activities as well as coming up with a plan. So after all of this, and then again, he did have a previous admission of acute pancreatitis. So hopefully he received some education at his prior admission, but then again, he came back. So the information that he was taught before didn't really stick. So this would be considered a knowledge deficit as a nursing diagnosis. So the complete nursing diagnosis is knowledge deficit related to diagnosis of acute pancreatitis as evidenced by the reoccurrence of acute pancreatitis, an elevated blood alcohol level, and failure to adhere to the low-fat dietary guidelines. So now we have our teaching strategies. The cognitive, 2 psychomotor, and then affective kind of plays in to our last activity as well, which will help to combat that knowledge deficit and ultimately prevent that readmission of acute pancreatitis. So our first teaching strategy we have is our cognitive strategy. So I created a pamphlet to take home with the patient. So we're providing education with a pamphlet regarding the disease process, risk factors, manifestations, and then the overall treatment of acute pancreatitis. So then I will be evaluating the patient with a mini quiz, and hopefully he'll get a 100%, showing that he retained that information. And then the goal again is to prevent that reoccurrence of acute pancreatitis so that he does not come back with another admission. So I will take the camera at this time. And I will read through the acute pancreatitis pamphlet. So what is it? Acute pancreatitis occurs when there is an inflammation to the pancreas. Chronic alcohol intake is the second leading cause and is more common in men. And again, my patient, his blood alcohol level was elevated. He said he wasn't drinking alcohol, so we are taking that into consideration. But just so that he knows in his pamphlet to take home that alcohol is one of those causes. So then as you can see, I highlighted some information in the pamphlet itself. The highlighted information is what my patient actually experienced, so that when he goes home, he can say, oh yeah, I smoke, I have a high-fat diet. So then he can look through and he can kind of reflect on his experience that he had himself. So the risk factors include being an African-American descent, high alcohol intake, smoking, and a high-fat diet. Recognizing the symptoms, so severe abdominal pain and tenderness, radiating and deep and piercing, hardened abdomen, nausea and vomiting, a low-grade fever, low blood pressure, increased heart rate, and a yellowish tint to the skin. So then what tests can be done to see if I have acute pancreatitis? So first there's that blood draw, which tests a series of different lab tests. And then it highlights the amylase and lipase. His lipase was elevated. Other enzymes that can be abnormal are the liver enzymes, triglycerides, blood sugar, and serum calcium. Various scans may be performed to visualize the pancreas for the collection of fluid or blockage. He had a CT done, which again, that did show the free fluid in his abdomen. And then he had, you could have an abdominal ultrasound. So then how will I be treated? So your doctor may prescribe various medications to control your pain and promote the healing of your pancreas. So medications for pain control are the morphine and Dilaudid. To decrease the pancreatic enzyme release, the Diamox. Neutralize or decrease stomach acid secretions, antacids or protonics. And then additional measures, strict NPO, nothing by mouth diet. Again, letting the stomach rest so that we can decrease the secretions that are being produced. Nasogastric tube placed if needed, and again, to allow rest. Hydration with fluids, and surgical removal if gallstones are evident. Then we go to the back of the pamphlet. So what can I do to prevent acute pancreatitis? Prevention is key for this. Make sure you're taking your medications to control your pain and reduce those acid secretions. Eat a low-fat diet. Those high-fat foods stimulate the pancreas more as compared to carbohydrates. Avoid binging and crash diets, and refrain from that alcohol use. So then the nutrition guidelines, which will come to play in the next activity that we do as well. So here I provided some education for that activity in advance. So nutrition guidelines, again, we want that low-fat diet, as it's difficult for the pancreas to digest fat during acute pancreatitis. So we want to choose foods low in fat. So the recommended foods are low-fat dairy products, fresh, frozen, and canned fruits and vegetables, whole grain bread, cereal, pasta, brown rice, lean cuts of beef and pork, and then again those unsaturated oils, peanut oil, olive oil, sunflower, and canola. All right. come to our psychomotor activity. So the psychomotor activity consists of a hands-on activity that requires the patient to make 3 different meals, putting them on his plate, and then picking out those ones that are low fat. So then evaluation, we would be assessing in a group, so I would be having a discussion with my patient. He would be telling me what items he chose for his meal. And the goal is that the patient will practice selecting those low-fat food items that will prevent the development of acute pancreatitis after discharge. So you want him to go home and actually choose these items instead of choosing all of the high-fat items. So I'll take the camera again. So this was a plate for my patient to have. And then here were some food items that he could choose. So, he'd go through and he'd say, I can have the fat-free milk. And then he would maybe say, I can have the, this is corn. There's not much fat in that. And then maybe he'd say, tequila. Well, you probably shouldn't have tequila because, again, that's the alcohol. So we don't want that. But then he could have some brown rice. And then, what else here? He could put Cheerios on his plate. Really selecting those low-fat items and showing that he's competent in choosing them, so that when he goes home, he knows what to eat that adheres to the appropriate dietary guidelines. All right. And then we have our last teaching strategy, our effective. So we are going to develop a list of short and long-term goals, state how the goals will be achieved, and then the positive outcome that will result by meeting that goal. So then the evaluation will happen again with a discussion between the patient and myself, and then their ability to relate a positive outcome with that goal. So then again, our goal of the activity is that the patient will identify a positive outcome, and then that will increase his motivation to actually achieve that goal and take action to it. So I'll take the camera. I created a worksheet. So this activity pertains to like hands-on psychomotor. We're making the goals ourselves, writing them down, and then the effective is bringing in that positive feeling to it, that emotional appeal. So we have a couple short-term goals and long-term goals. So if I would, let's say a short-term goal could be that he goes home and remains pain-free. He doesn't want to experience pain, so he wants to be pain-free. So his plan could be that he is taking his medications as prescribed, writing them down, creating checklists. And then the outcome would be that he feels better. He's able to do things that he normally would be doing. He'll go to work, spend time with his kids, seeing that positive outcome, which will make him feel more motivated to do it. And then again, this is the planning activity that he really enjoyed with the dietitian. Having it written down in writing, having a plan set in place. So hopefully he'll be more apt to do that. And then again, this is my teaching plan. And I will upload everything to Schoology. I had originally made like bags for each of the students to create their own meals and their own pamphlets and such. So I will upload all of this. Thank you.